Thank you and the organizing committee for the honor to speak with you today. You've asked me to talk about acute on chronic heart failure shock. Cardiogenic shock, as we know, still continues to be a major source of both morbidity and mortality for our patients. And despite the further clarification by SCAI and helping us identify patients who are at risk of developing shock, we still have mortality rates for patients who develop SCAI stage E exceeding 50%, both in the ICU and up to 70% during their hospital stay. Cardiogenic shock can be identified by a number of different factors. Hemodynamically, we look for patients who have a systolic blood pressure less than 90 millimeters of mercury, or if they're requiring inotropes or pressors to maintain an adequate blood pressure. Clinically, they also appear to be cold, clammy, or often tachycardic. And looking at biomarkers, they have an elevated lactate, signifying they're hypoperfusing their organs. The etiology of shock can vary. It can be from acute MI shock, which historically we felt was the predominant form of shock. It can also be from chronic heart failure shock, and often an echocardiogram can help us guide to the underlying etiology, as well as a PA catheter to better define hemodynamics and look at a patient's cardiac index, their filling pressures, as well as their SVO2. When patients develop cardiogenic shock, they develop a spiral that hypoperfuses their organs and then can set off a cascade that develops into a cardiometabolic shock. It's critical for us to identify these patients early to reverse this downward spiral and achieve myocardial recovery for patients. The C3TN group helped us better understand who has shock in our CCU. They identified out of their cohort of 677 patients that 2/3 of the patients had cardiogenic shock. And of those patients with cardiogenic shock, 30% of them had shock due to acute MI, and 70% had non-AMI cardiogenic shock, of which predominantly they had either non-ischemic underlying cardiomyopathy or underlying ischemic cardiomyopathy without an acute coronary syndrome presentation. Other etiologies included patients with cardiac arrhythmias or valve disorders that progressed to cardiogenic shock. Sasan Sena from ANOVA and his colleagues also looked at AMI cardiogenic shock versus heart failure shock in their recent publication in Circ Heart Failure. Looking at the baseline characteristics of those who present with AMI shock, they're often older, more likely to have diabetes, more likely to have a cardiac arrest. They do more often receive temporary MCS support during their hospital course, and they often have major bleeding complications and vascular access complications, as opposed to those patients with acute on chronic heart failure who tend to have a lower ejection fraction at their baseline, a lower cardiac power output, higher filling pressures, and a higher pulmonary artery pulsatility index. The heart failure shock patients more commonly receive durable mechanical circulatory support or replacement therapy with a heart transplant and often have a longer length of stay. The one-year mortality for both of these patient populations remains high, with AMI shock still having a slightly higher cumulative mortality than heart failure shock. The shock working group has also helped us to better understand this patient population through their multiple publications, including this one from 2021 with Jaime Hernandez as the first author. The heart failure shock patients are often intubated and require mechanical ventilation. They often require multiple inotropes or pressors and multiple devices. They have biventricular failure, often with an elevated right atrial pressure, as well as an elevated wedge pressure. But up to 40% of the time, they may have an elevated cardiac index and not necessarily what we would have thought as a low cardiac index. However, they do have a dominant phenotype of hypoperfusion. Even if their cardiac index is elevated, they often have signs of renal failure with an elevated serum creatinine and hepatic congestion with an elevated INR and an elevated total bilirubin. The shock working group looked at the SCAI stages and added further clarification to facilitate identifying these chronic heart failure patients earlier in their trajectory. They added, in addition to hypotension, looking at both systolic blood pressure and a map, signs of hypoperfusion, looking at lactate levels, ALT levels, and a serum pH level. They also included treatment strategies because often these patients may have an inotrope started or a balloon pump placed before they have hemodynamics that are captured, or even at the same time that they have blood drawn for biomarker assessment. So you can see the early identification of that SCAI stage B may not necessarily be hypotensive, but will have signs of hypoperfusion. Furthermore, the shock working group looked at the etiology and outcomes of cardiogenic shock and looking at those patients who have acute MI versus heart failure shock. You can see the heart failure shock patients have a lower in-hospital mortality at 25% compared to the MI shock patients who have an in-hospital mortality of 42%. For both cohorts, however, if they do suffer a cardiac arrest, whether it's in the hospital or outside the hospital, that does increase their mortality rate. Interestingly, when patients present with SCAI stage B, many of those patients do progress to further higher classifications of SCAI stage. So when looking at the baseline SCAI stage, you can see SCAI stage B actually has a higher in-hospital mortality than SCAI stage C, but their mortality is also dominated by the maximum stage the patient develops during their hospital stay. You can see the mortality remains high for both acute MI patients as well as heart failure cardiogenic shock patients across all stages. Looking at that heart failure shock patient population, if they present with a SCAI stage B presentation, 90% of those patients develop to further SCAI stages. And looking at the figure on the right, of the patients who present with SCAI stage B, the number was 225, 145 of those patients progress to SCAI stage D, where you see the mortality increases as patients progress to SCAI stage E, and that maximum stage tends to emphasize their overall mortality more so than the beginning stage. And interestingly, it only takes a medium hours of 52 hours for the patient in SCAI stage B to progress to its maximum stage during their hospital stay. So rather than thinking of SCAI stage B as a beginning shock, it helps us to think of SCAI stage B as bad because these patients are at high risk of progression of their SCAI stage, which also lends to a higher mortality rate and emphasizes the importance of surveying these patients early after their hospital presentation and continuing to monitor them for progression into this further SCAI stages. Also looking at the etiology of heart failure shock, many of these patients have acute on chronic heart failure, but some do present with de novo heart failure shock. The etiology for the de novo shock is often idiopathic, but can be due to arrhythmias, either AFib with RVR or VT, as well as myocarditis. The de novo patients have a higher in-hospital mortality rate than those patients with acute on chronic heart failure and more resemble the population that we see with AMI cardiogenic shock with a higher mortality rate. Yet they also have a higher chance of native heart for survival. You can see 58% of these patients were able to recover and keep their heart and not require heart replacement therapy. So when we look at phenotyping the heart failure shock patient, you can think about the patient who is not congested as having lower filling pressures, mild to moderate hypotension, But as the patient starts to develop congestion and elevated right atrial pressures that we know contributes to cardiorenal syndrome, that patient then transitions to a cardiorenal phenotype of cardiogenic shock, where they have more moderate hypotension, they may have worsening renal function, and elevated right atrial pressures, as well as an elevated wedge pressure. And then ultimately, the patient will progress to cardiometabolic shock, where you start to see the manifestations of hepatic congestion. You have elevated filling pressures, elevated ALT, worsening serum creatinine, and elevated lactate, and severe hypotension. This was a publication from the American Heart Association that emphasized the need when patients present in cardiogenic shock to assess for the etiology of shock. Is it an ACS-mediated shock that requires reperfusion, or is it chronic heart failure shock? And the importance of identifying patients early in their course if they are a palliative care patient versus those who are candidates for myocardial recovery, and to aggressively evaluate and support patients who need temporary mechanical circulatory support, to emphasize the importance of heart recovery in those patients, or bridging those patients to a more durable VAD or replacement therapy. So shock requires a heart team approach, and certainly over the years our heart team has evolved and now incorporates cardiac surgery, interventional cardiology, heart failure specialists, general cardiologists, even, and more recently, critical care specialists and intensivists, as well as palliative care and emergency medical teams. It's important that we have good communication among all team members to focus on patient-centric outcomes and have that shared decision-making with their patients from the time they're picked up by the EMS team till they land into the ED, and whether they go to the ICU or to the OR for appropriate MCS support. So looking at a high level for MCS selection in our patients, it does require upfront a multidisciplinary heart team approach to not only identify whether the patient has BIV shock, RV dominant shock, or LV dominant shock, but also to look at the most appropriate therapies and who is available to treat the patient. At 2 in the morning, you may not have a surgeon available, but you may have an interventional cardiologist who can certainly implant an Impella CP or a right-sided device in the cath lab or place a patient on ECMO, but you may not have a surgeon available till the morning where you could implant a higher flow device such as an Impella 5.5. So in mirroring the success of AMI shock, I wanted to propose a best practices algorithm for acute on chronic or even de novo heart failure cardiogenic shock. We've learned from the cardiogenic shock working group that this patient population is dominated by hypoperfusion, so it's important to recognize these patients even if they're not hypotensive, but they're showing signs of hypoperfusion. So early identification is critical, and looking at those markers of perfusion, including a lactate, your liver enzymes, your renal function, your urine output, as well as looking at a new metric called aortic pulsatility index, which simply takes your pulse pressure and divides it by your filling pressure. We've known historically that patients with chronic heart failure often have narrow pulse pressures and high filling pressures, and this is a numerical assessment of that response to identify patients who are at high risk and identify them early so they can be stabilized, and then take the patient to the cath lab for a right heart cath and consider if that patient needs a coronary angiogram. More than 50% of the time when patients with heart failure present in cardiogenic shock, there is no assessment of coronary anatomy. Many of these patients may have diabetes, microvascular disease, or atypical symptoms of angina that don't manifest as chest pain. So underlying ischemia can be under-recognized and undertreated in this patient population. And certainly it takes a heart team approach to guide your strategy after evaluating the diagnostic information from a right heart cath and coronary angiograms to determine what is the best strategy for treatment for this patient. And looking at the exit strategy is critical upfront before defining the MCS strategy or the revascularization strategy. Certainly with revascularization in this patient population, it's challenging to revascularize any patient in the setting of cardiogenic shock, except an AMI shock, where certainly it's critical to unload the ventricle and open the infarct-related artery. But with more chronic three-vessel disease, it's important to stabilize that patient and then ascertain, is that patient a better high-risk CABG patient? For example, with a diabetic who we know would have benefit from a LEMA to the LAD, or does the patient have multiple comorbidities that would make them a very high surgical patient, and would they be better served with a percutaneous approach? And looking at the right heart cath to guide your MCS strategy, again, focusing on evidence of hypoperfusion as well as hypotension. If the patient has one or two signs, you can certainly start with inotrope suppressors or even a balloon pump, but it's critical because of the high risk of a SCAI stage B patient progressing to SCAI stage D or E to reassess these patients every 2 hours. Similar to if you had somebody who presented for concern of acute coronary syndrome and the first EKG did not show ST elevations and the first troponin was flat, you would do serial EKGs and serial cardiac enzymes. Similarly, in this patient population, if the patient presents more in a SCAI stage B of shock, it's critical to continue to reassess the patient frequently and assess if the patient would benefit from escalation to mechanical circulatory support early to maximize the patient's opportunity for heart recovery. And using the right heart cath to guide the treatment strategy for any MCS, as well as whether the patient has a need for oxygenation or just unloading the LV and dropping the wedge would be enough to maximize their oxygen status. We learned years ago from Lou Samuels, a surgeon, that high doses of inotrope suppressors cause in-hospital mortality. And even at 2 high doses of vasoactive medications, the patient has a 42% risk of in-hospital mortality. And this was based on well over 3,000 patients. And if the patient requires 3 high-dose vasoactive medications, their mortality risk is 80%. The heart team evaluation is key to identify both our exit strategy and to guide treatment. In addition to normalizing hemodynamics and recovering end organ function, it's critical to assess the patient's nutrition. Their frailty, we know, correlates with poorer outcomes. And as we remember from the early durable VAD days, malnutrition was the #1 predictor of death in those patients. So certainly in bridging a patient to replacement therapy, it's critical to take time to optimize their nutrition, improve their frailty by ambulating patients before transitioning to a durable VAD or a cardiac transplant. Ongoing monitoring to assess for timely escalation as well as to assess for weaning is critical. These patients can develop more of a mixed picture when they go into a cardiometabolic state, and it's critical to continue to assess the patient to see if they have an adequate cardiac output or they need an escalation of their support to a higher flow device. So in conclusion, our heart failure shock patients are different from our AMI shock patients. An early hemodynamic assessment assists us in the diagnosis of heart failure-related shock, as well as guides our treatment strategy. It's critical to continue to monitor these patients closely because of their extremely high risk of progressing in cardiogenic shock, and identify early both the need to escalate on the left side as well as if the patient needs right-sided mechanical circulatory support. And shock teams have shown to improve survival and are critical to the management of these patients and drive improved outcomes. With that, I thank you for your time and attention. I'm happy to take any questions.